Thanks for that, Brian. Yeah, it was okay for me to be in shorts and sandals because I was working in a genetics lab working on Drosophila genetics. Just to be clear, I wasn't doing anything that required dressing up. So it's a pleasure for me to be here. Happy New Year. Thanks for coming to the first grand rounds of this 2000. Oh, I already put the wrong date on. I had to do it at least once this year, so got it over with in a big fashion. And it looks like it's going to be quite a year from a virologic perspective. I suspect most of you in here have either been sick or have had family members that are sick or have family members calling you about their kids that are sick. And what I'm going to show you today is some tools that we've been working on for several years, many years, to try to provide information to clinicians and more recently consumers to help aid in that ever-present and persistent problem of viral illnesses that sweep through our community. Make sure to turn this on. Here we go. So quick disclosure, my spouse and I have no relevant financial interests. The system I'm going to describe and show you is constructed with specific software products, which I'll try not to name, and could be built with a variety of offerings. I have recently received a little bit of salary support from Intermountain to help build and maintain this GermWatch system, which is being provided as a free service. So I'm not getting paid by a GermWatch company, for example. And I may by accident plug Verizon because the screenshots I put into the mobile app, I didn't get a chance to scrub Verizon off the top. But you can use whatever cell phone carrier you want to access this information. Okay, so quick, we're going to go over information technology, give you a sense of how we're using it to transform the data that routinely gets captured during your work, our work, to turn it into information that can be useful for point-of-care decision-making and informing your patients and families, and try to understand how that can actually lead to potentially better outcomes, support your clinical decision-making, and ultimately enhance our healthcare delivery in the state of Utah. I'm going to embarrass Kent Korgensky. He may be probably the most acknowledged person in the grand rounds, I would say. I don't know if anybody keeps that statistic, Joyce, but I think Kent shows up on a whole bunch of slides and talks. That's because he's quite a wizard with data and very knowledgeable in Intermountain information systems. I got to acknowledge Brent James, who helped me early on out of my residency and gave me a home to sort of foment some of these ideas and work on them, and was very supportive of the concepts. Carolyn Reynolds in the pediatric clinical program that's given GermWatch a home for the last several years. And the infectious disease division, Andy Padilla, Carrie Byington was very influential for me, and all the PEDS ID folks who've sort of contributed ideas and content over the years to help make this tool better. And then a couple of shout outs to the Intermountain folks, especially the EDW team that have invested a lot of effort and time to make sure our data structure is intact and operating on a day-to-day basis. And then people in the Intermountain e-business team that had the foresight to understand how the potential impact and reach of these applications and contributed resources to developing some of the things I'm going to showcase for you today. So Brian mentioned that I got my start in, at least in academia to a certain degree, in biosurveillance. I came out of the University of Minnesota med-peds residency. I started moonlighting early in residency, like second year, and would plunk into these communities in the Twin Cities, which is a big town, and start seeing adults and kids, and they'd come in sick, coughing, and I was frustrated and not wanting to give in to what the drug reps told me, just give them the Z-Pak, give them this other antibiotic that they didn't need, and wondered, boy, wouldn't it be great if I could learn from people around this community and know what was actually happening and what was going through, because it would make me a better clinician. So coming out of that experience, I got into medical informatics. When I got into medical informatics here at the University of Utah, I had these ideas about capturing data from multiple places, integrating it, putting it back out there, and my department chair and mentor at the time told me, that's crazy, nobody's ever going to share data like that. And along came 9/11 and the Olympics knocking on our door, and all of a sudden people were like, oh yeah, this makes a lot of sense, we should get on this and do that. So that became the subject of my thesis, was putting together a real-time syndromic surveillance system that allowed us to track, at least at the state level, respiratory illness, GI illness, and be able to do it in real time and analyze those signals. And that was all fun and really exciting. George Bush, when he visited University of Pittsburgh around that time, saw the system that we put together for the Olympics and likened it to the defense early warning systems that was in place way back when. And that was quite an honor. So that was good work, and we enjoyed that. It led to a lot of the surveillance stuff that's being done by the CDC right now with biosense around the country. But what frustrated me was that it was tracking respiratory illness, GI illness. It didn't actually tell me what was causing all those syndromes, right? So I wanted to dive more into the stuff that I originally got interested in, was these respiratory tract infections, these viral infections that exact a huge toll on our society and have a substantial health burden. Because because this audience is pretty knowledgeable about that, I'm not going to go too deep into this, but suffice it to say that those viral infections, influenza and non-influenza, influenza-like illnesses account for, at a minimum, probably 7 to 10% of all visits in the ambulatory setting. And if you get into the acute care setting, emergency departments, and urgent cares, it's probably the majority. There's billions and billions of dollars spent every year, about half of that in direct costs, people spending money on doctor's visits, prescriptions, over-the-counter medications, and then there's indirect costs, people missing work, lost productivity, a huge toll. And one of the big problems is people getting antibiotics when they go in there frustrated and wanting help and wanting to feel better, clinicians wanting to do something and help them, giving them a prescription for antibiotics, and maybe that's 50% of the time not necessary. When you get those antibiotics, you have adverse drug events, you get resistance, you get disruption of your microbiome, which we're learning more about and what kind of havoc that wreaks on people. And then from Ed's perspective and all of our perspective, a huge surge in healthcare utilization and an impact on sort of workforce, especially in children's hospital type settings. So we set out to develop tools that were sort of tailored for clinicians. What I really wanted to do, make them useful for diagnostic, testing, treatment decisions, make them useful for having discussions with patients and parents to make that 10-minute painful why you don't need an antibiotic discussion more like a 5-minute you don't need an antibiotic and here's why and here's what you can do to help yourself, and everybody leaves happy. And then recently in the last several years we've recognized the value this would have to consumers, and we turned our attention towards developing a resource for them, and I'll show you that in just a little bit. So as we move forward, I want you to reflect on the kind of information that you think would be helpful for tackling these problems. This is the short list I came up with. At the top, it's information about those regional and viral outbreaks. Can you have situational awareness? Can you answer that question of what's going around so that people know what's circulating in their communities? Can you provide information to support empiric or best guess antibiotic prescribing when you do think a bacterial pathogen is present, or you have a condition where a bacterial pathogen is often present and you need to provide the most targeted and effective antibiotic for that condition. That information can come in the form of antibiograms and care process models, which I'll show you as well. And then what we've been working on for the last several years is try to get a little better understanding of what's happening with these epidemics. Can we do a better job predicting, forecasting, so that I can, tell folks a few weeks out what we may expect, or even a few months out what we may be seeing. And that has implications for not only managing your workforce, but we think, and I'll show you some examples, of being able to preemptively get ahead of some of these outbreaks and inform the public about what may be coming and how they can get more knowledgeable and prepared to deal with what may be coming at them in the near future. So in Utah, we have the luxury of having an integrated healthcare delivery system in Intermountain Healthcare that provides statewide and even some southern Idaho coverage with their 22 hospitals, 180 plus clinics with integrated data systems, so that we can get a pretty good snapshot of what's happening for our population. It'd be ideal if we could get everybody, but we get a pretty good snapshot with just Intermountain system data. And you've seen some graphs like this before. Dr. Clark presents these at Grand Rounds in a slightly different format, where you can see this is the last 10 years of viral epidemic activity, and you can see the heavy hitters, as I call them, RSV, metapneumovirus, influenza, coronavirus, that come every year. They may vary in size and in intensity and duration. And you see parainfluenza that does this sort of beautiful dance where they push each other around and show up in alternating years. And then you have less common endemic pathogens that sort of circulate at a baseline level and surge up and down periodically. And the challenge, this is easy to, well, not necessarily easy, but you can go back, query this, and put together a retrospective slide. But now thinking about how you put this into a more real-time system that spits it out on a weekly basis, for example. So at a high level, the kind of system that we've been working on, we call GermWatch. It's a collection of technologies that comprise both the testing, the microbiological testing, the electronic health record data, the collection of that data, where a lot of the magic happens in the enterprise data warehouse. I'll focus on that a little more in the next slide, where we can do combine the diagnostic data with additional administrative and clinical data and populate these tables that allow us to generate all these data visualizations, which you'll see a whole bunch of in the next several slides. And the next key is the dissemination vehicle. How do you get that stuff out? The various channels we're using, websites, apps, email, and we'll go through all of those. So as we drill in, comprehensive microbiologic data, So basically anywhere throughout the Intermountain system, if you get tested for one of the pathogens that I'll show you on the next slide, it winds up in the enterprise data warehouse in their laboratory, from their laboratory information system. Clinical data, likewise, any of the ICD-9 codes, ICD-10 codes that get generated in the clinical settings, all that winds up in the enterprise data warehouse. We're able to pull all that data into a dedicated schema. I'm going to use the pointer here for the online folks, where a lot of the magic happens. So here we're able to pull in, we're able to find out what the test is, what the name is, how's that test represented, so that we can tally them all up. We're then able to load lighter weight tables into what we call tactical databases that can serve up the mobile application. We are able to run business intelligence software against those that can provide analytics and dashboards, which you'll see some examples of. And then we can spit all that out to these various channels, including mobile applications, clinical websites, and a weekly email web distribution. So you have all this data. You have to have an approach to doing case detection. How are you going to detect cases of interest for the conditions that you're trying to track? So a few different levels at which we're doing that. There's laboratory confirmation, obviously the most sensitive and specific way to do it. Molecular diagnostics have really exploded in the last 10 years. They are very sensitive, very specific. They test for a whole panel of pathogens. You guys are all familiar with the respiratory film array, the GI film array. There's mini PCRs, there's still DFA being offered, there's cultures, and there's even point of care testing. We can grab all of those. The trick with that signal is that it's limited to those that get tested. So it's just the tip of the iceberg, it's not everybody. To try to get the rest of that iceberg, we're looking at clinical diagnoses and going out to the primary care clinics where we can tally up ICD-9 codes entered by clinicians and or coders. This is dependent on clinicians being precise and good diagnosticians, but if they do a pretty good job, we can tally up those as well. Some of the stuff we're working on that's a little more cutting edge is doing probabilistic detection of cases where we're using emergency department dictations and combing through those using some natural language processing extraction techniques and trying to see if we can pick out cases of influenza, RSV, metapneumovirus just by using machine learning methods and some fancy math to say this patient has a probability of 90% that they have influenza just based on what the ED docs described. And that's looking pretty promising, but is currently just retrospective only and has a lot of moving parts in order to make it work in a real-time fashion. So just real quickly, the pathogens that we're able to cover because of all those tests that are out there, respiratory pathogen list is pretty extensive. You've seen that on your RFA reports. The gastrointestinal pathogens, similar, those came on in the last couple of years. We're starting to gather those, track those. The syndromes that we're currently tracking are pharyngitis, because there's an interest in sort of being able to track strep throat, perhaps at the population level, bronchiolitis for all causes. We're able to do an enterovirus-like illness signal, because it kind of presents pretty distinctly with herpes angina, hand, foot, mouth. So if you're coding those out there in the clinic, we can track those. And influenza-like illness, anything that gets coded like that as influenza, we can tally up. And then acute gastroenteritis. So I'm going to march through the individual channels that we're sort of using to get this information out there. The first one is going to be our iOS app that's for clinicians. I first of all apologize to those of you who don't have iOS, or if you're on Android, because we don't have it yet available for that. And it still requires an Intermountain login. We're working on getting logins removed both from this and from the doc site, but that's a work in progress. But to walk you through that, if you go to the App Store, you can find it just searching for the GermWatch app or for Intermountain GermWatch. And what that app looks like, and I encourage you to download it and play around with it and let me know if you can't get access to it so I can advocate that you can. But at a high level, you can see a very simple bulleted summary and a lot of feedback from the clinician end users. They wanted spoon-fed, give me 4 points, 3 or 4 bullet points so I can quickly look at it. And then if I want to drill in and get more information, I can do that. You can see that we sort the pathogens by their activity level, and this is a real graph. This is no joke. This is what's happening with influenza A right now, just taking off. You can see along the top here that you can actually specify the seasons that you're interested in and get a comparison, quick comparison this year versus last year, how bad things are. You can do the same thing for the gastrointestinal pathogens as well as syndromes. So you can get a very quick look at what's happening just by going through that application. We have been taking some of those lessons that we learned and functionality that we got built into the mobile app, and we're rendering that now on the public face or the clinician-facing GermWatch site. I'm still calling this a beta because we're struggling to get some of the final pieces built and some of the bugs out of the last little bit, but the surveillance data is quite accurate, and the graphs are quite accurate, and the maps are accurate. But if you go into here, you may still find some sections that are in development, so be forgiving because we're still working on that. But you can get to this application, this website, by just browsing to germwatch.org, and right above where you can get a consult with Larry David from Seinfeld, you can access the GermWatch physician site. And most of this stuff you can find, if you can remember one thing from today, at germwatch.org, you can get to pretty much everything that I'm going to show you today, one way or another. We've been doing emails for a while, and again, one other apology, and this will be my last apology for the grand rounds, is that our email distribution service was disrupted a little bit for the last few months because we've been having competing interests with information system enhancements and things going on. So we've had struggle to make sure our reports were exactly how we wanted them, and then bringing up a new email distribution service. So I expect those issues to all be resolved in a matter of a week or two, and we'll be kicking back off emails. So we've missed a couple months this end of this year, but that'll be ramping back up. So far, we're reaching over 800 users. A number of those are get direct burst reports from Kent Korginski that are specific to facilities and show you exactly what's happening at your facility. There's statewide, and then there's special case reports. Because our data is so rich, we can turn on daily influenza reports that have a lot of detail about what's happening with influenza patients. Were they in the ICU? Were they on mechanical ventilation? We can provide those line lists to the hospital epidemiologist and the infection control practitioners that have to review those. We can turn on measles when it's needed. There's a number of things. We can turn on special E. coli reports if outbreaks comes up. So we're pretty nimble in terms of coming up with special case reports. And these emails basically entail a high-level update. Again, that summary, spoon-feed me a few points, a high-level summary graph at the state level, and then the ability to look at weekly surveillance summaries that are at a region or system-wide perspective. This is a little overwhelming, I'll admit, but this is one of our information dashboards that summarizes all of the respiratory activity, and this one I pulled up just from this last week. So this is hot off the presses. And walking through this, I'll use the pointer to help the online folks. You can see that influenza is increasing. There was a total of 2,800 tests. There was 36% positive. This graphic shows sort of the positivity by region. These regions don't mean anything to you unless you're sort of in Intermountain, where there's everybody, North region, Central region, primary children's, South region, Southwest region. And you can see that our epidemic curve is marching up. So this is actually kind of a depressing report, especially heading into January and several weeks of service. So RSV is out there rumbling, just starting to tick up. Metapneumovirus is taking off. Parainfluenza is coming down, although we bump back up just a little bit. But you can get the idea that if you get used to this report, at a quick glance, you can sort of see what's causing trouble. You got things that are high, things that are moderate, things that are low. And this has been one of our popular reports for getting a quick look at what's going on. You can also see that we have lab-confirmed bacterial surveillance over here, so we can track pertussis, we can track strep throat, mycoplasma, chlamydophila, and you can see what's happening with our syndromes. In case you might think that, oh, everybody's just testing a lot more patients for influenza. No, these are actually the influenza-like illness counts from our clinics, and they're also taking off as well. Bronchiolitis, mercifully, is just sort of smoldering along, hasn't kicked in just yet, but that will come. It will come. So to sign up for that email, there's a few ways you can get to it. If you're on the physician's website, you'll see this cute little icon that says disease update description. That'll take you to a website that just asks you to put in your email, a little bit of information about you, like what your region is, what your role is. That helps me keep track of where my users are and what kind of user they are. You could also go to the generic GermWatch email and send an email with a sign me up in the subject line with that information as well. So if you want to circulate that around, get people signed up, we're looking to grow that user base and get more people signed up for that email distribution. All right, now shifting gears. So you now have a great picture of what's happening from a virology standpoint. You know what's out there, influenza, RSV, parainfluenza. You're doing your best to deal with the clinic surge and help with those people. But now you have a patient where you think, oh, they've got a condition where I actually need to prescribe them an antibiotic. I'm no longer trying to talk people out of an antibiotic. I'm like, I need to prescribe one. Where do I go for information to help me make an informed decision about antibiotic prescribing? So that's where antibiograms can come in handy. And an antibiogram is a collection of data, usually in the form of a table, like this very hard to read table over here on the right, that summarize the percent of individual bacterial pathogens that are susceptible to the different antimicrobial agents against which they were tested. For a long time, you guys have seen these in the form of a pocket card that get printed and distributed throughout the hospital. We early on recognized that we could do a little bit better than that. And in fact, the first thing we built in our mobile app was an antibiogram application, which I'm going to walk you through shortly. And I'm also going to show you a web-based query tool that's been developed by some of my informatics colleagues at LDS Hospital. So let's just walk right through that. So on the GermWatch app, the top one's antibiogram, the bottom one's surveillance. If you click on antibiogram, you're going to go to an interface that gives you a few different mechanisms by which to look at antibiogram data. Perhaps the most useful one right now is the organism section of this application. So in this section of the application, there's 5 different hospitals are all Intermountain. We went for the big volume hospitals. We did just simple bifurcation, adult versus pediatric. And then there's 80 plus organisms that you can look for in here. And right now it's sort of urine versus non-urine in terms of your sources of where you can go. But this has essentially replaced the pocket card for primary children's. And if you select, for example, here, E. coli, primary children's less than 18, you get presented with this information, which shows the antibiotics on the left column, a cost figure, which is based on the average daily cost, with the $3 signs being very expensive, $1 sign being pretty cheap. And we've done a couple of interesting things here where you can see inpatient, you can see ED or outpatient, and then all patients all in one spot. So in some cases, there's really meaningful differences between what you see for inpatients versus outpatients, and this can help you see those types of differences. The other section of this application is a syndrome section where I neglected to put those actual syndromes on there, but we have bacteremia, cystic fibrosis, osteomyelitis, meningitis. What am I missing, Kent? Urine, your UTI, of course. So those are the 5 syndromes we've worked on so far. We now have a nice infrastructure for expanding that. So if you guys have an interest in a specific syndrome relevant to your specialty, or something you want us to try to flesh out whether we can do that for you, reach out to us. We can work with you and see if that data may be available to present a specific syndrome relevant to you. The last section on this I'm not going to cover for the sake of time because it's still early in its development, is what's called an empirigram, where we're weighting the number of isolates and sort of taking into account all the pathogens that you might associate with a condition. Right now we've only got it for urinary tract infections and ED patients, but it gives you a breakdown of a percent coverage. If you were to choose an antibiotic, of all the things that might be isolated, what would your percent coverage be? And we're, I'd say, in the early phases of figuring out what to do with that functionality. The other tool I wanted to tell you about is the antibiogram tool. And again, this is available through the physician website. You'll see this little antibiogram tool link. This was developed by Scott Evans and Jim Lloyd up at LDS Hospital. The problem with this application right now is it's totally behind the firewall. You have to be on an Intermountain system, and in order to look at this data, you can't access it outside. And that has to do with people being a little bit cautious about wanting to get antibiotic resistance data out there into the hands of whoever might want to look at it. So that if you have a hospital that's got really bad resistance patterns, theoretically you could surface that type of information here. So they're a little bit cautious about circulating that widely. But this tool gives you an incredible amount of granularity with which to, whoops, what did I do there? I need my guy. Is that the quote? Oh, there we go. I got it. Just hit up spacebar. That's all it took. I got confused. So, and to some degree, this is probably too much information for you to have to specify. And there's an incredibly long list of organisms, and there's a lot of different places you can do it. But if there's a question you want to ask specific to, sputum and the ER and nursery, you can try to find an antibiogram specific to that. And if you're lucky enough to find that and have good data, you'll be able to have that specific report, and you can even print that and save that. So we're trying to create sort of a spread of offerings. One sort of quick access, the most commonly used stuff, going all the way to incredibly detailed, ridiculously level of detail for getting antibiotic resistance information. So what's powerful about this, behind all this, is now what Kent and I are calling a single source of truth for antibiotic resistance information. So it's system-wide, it's been curated, it's been cultivated quite nicely, and we believe the information that's coming out of it. And that data, besides what I'm showing you in terms of accessing it through these various channels, is being used routinely to inform development of care process models throughout the Intermountain system. So for conditions arising, from a bacterial infection in a decent chunk of cases, and for which knowledge of incidence of those bacteria and their resistance patterns can inform your decision-making, those kind of conditions now, we can quickly turn to this data source and pull local information and weave it into the guidance and care process models that are coming out of the Intermountain development teams. So Kent and I worked with both the pediatric and the primary care clinical programs to develop some of these care process models. I'm just showing you the pediatric specific versions. Right now, we obviously have febrile infant, we've got otitis media, we've got community-acquired pneumonia, sinusitis. So where the national guidelines talk about doing X, Y, and Z, and then refer to your local data to tweak this piece, that's essentially what we're now able to do in a very nimble fashion. So we're also developing urinary tract infections, skin, soft tissue, and neck infections, and I'm sure I left off a couple here as well. So where can you see those types of decision support aids right now? Well, those pocket cards were formatted to, again, print on a card, fit in your pocket, but they're also able to be pulled up on your smartphone. If you go to the Intermountain Physician app, which is out there and available to you, you'll see that the best practice flashcards are right up here. You can quickly get to those, and then GermWatch is right below it, which is kind of nice. What I really enjoyed about this process is, there in a certain proportion, otitis media is caused by bacteria but a lot of it's viral. So let's drive those clinicians to GermWatch. Yeah, it's probably a viral. Why don't we take you over here so you can get caught up on what's happening from a viral perspective and take them down that path instead of giving them an antibiotic that they may or may not need. So this information is also woven into the fabric of the order sets and the power plans that you're seeing as well. Where we're headed from a future state is really trying to make these tools a little bit more dynamic. And by dynamic, I mean that you're actually pulling data specific to that patient, what their allergies may be, what antibiotics they may have been on recently, what some clinical features that you can pull out of the electronic medical record, and really start to try to tailor those recommendations specifically to that patient and make it really easy. There's a couple very compelling technologies that I hope to present more about in the future, where there's what's called a fast health interoperability standard, where electronic medical records are trying to make it easy for applications to consume data out of the electronic medical record, and then a platform for developing applications based on that standard that allows you to develop nice looking applications that can be ported between electronic medical records. You may have seen in iCentra there's what's called a smart growth chart. So that's an example of pulling data locally, and we're looking at this technology to do our next version of the community-acquired pneumonia protocol as well. So that's a compelling direction we're hoping to head in. All right, again, shifting gears. So clinicians, access to viral surveillance data, everything they can to try to not prescribe antibiotics. When you do need to prescribe antibiotics, you have access to good information and evidence-based guidelines and locally informed guidelines to do that, to how do we empower consumers? And this was something that Dr. Clark had asked me many, many years ago. We got to get this in the hands of the clinician or the consumers. And initially we had some trepidation, at least I had some trepidation about doing that because it seemed to open up this whole can of worms. But in the last few years, we've really embraced that, and it's been a lot of fun, and I think it's been really popular, and I'm hoping to demonstrate some impact of that as well, short of just utilization of the tools. So everything I've shown you up to date, you can sort of see why, you can't just turn that towards a consumer, right? It's you have to have some domain knowledge, you have to have some tolerance of some busy graphics and understand what you're looking at. So how do we retweak, how do we adapt this to make it useful for consumers? So we did some focus groups several years ago, getting together parents, first-time parents, some parents that were a little more experienced, and started talking to them about what they do at the first signs of illness when they have that kid with a fever and a cough in the middle of the night. And not surprisingly, found that there was a lot of uncertainty. They had a lot of desire to know what was going around and be more informed. They wanted to understand those signs and symptoms. They wanted to gain confidence in being able to manage them. They didn't want to necessarily have to run into the doctor or go get seen. They wanted to be able to anticipate, expect, and really know when they should worry enough and go seek care. Lots of discussion about frustrations with healthcare encounters, as you can imagine, feeling that they're walking in as uninformed customers, that their concerns are trivialized, that they're overlooked, getting unhelpful advice, which is just a virus, nothing you can do, or getting an unnecessary antibiotic, and more running into parents that get that antibiotics aren't necessarily the answer, and some feeling like, oh, they wanted to give me an antibiotic, I didn't want that, and feeling like they left without having very much information about their illness. And we also got some really good suggestions from them. They wanted information that helped them reduce their risk. Can they anticipate outbreaks? Kids that have, parents that have premature babies or children with asthma wanted to be able to have some idea of what might be coming so that they could be prepared and be on the lookout. They wanted a website that could be kept up to date with what's going around. Great, we can do that. Useful descriptions and advice for those pathogens and illnesses that are actively circulating. And they needed, obviously, to be in a patient-friendly manner that was easy to access, all in one place, clear instructions before seeing a doctor. And they wanted audiovisual aids to help understand the signs and symptoms and the history and progression. And then some of the more savvy ones were even an alerting system. Can you put me on an email burst where I can be notified of stuff coming into my community, which is a direction we're heading in. So out of that came the GermWatch.org consumer-facing site. And I'm going to walk you through the various components of that and just familiarize yourself. This is a site accessible to anybody, and it's been getting some good traffic. So we have a high-level overview. Currently, right now, it's just in textual format where we sort into high activity, moderate activity, low activity. And then if you click on those links, you get taken into what we've cleverly called Germ School. And in Germ School, you can learn about sort of high-level information about those viruses and their profiles, get up-to-date graphics, which are pretty simple epidemic curves, and maps, which I'll tell you a little about in a second. In order to put those maps out there, it took a fair amount of work organizing our data to get it so that we could surface the geographical information, and it had to be HIPAA compliant, so I can't put dots on a map by day of who had what where. So we took advantage of what are called small health statistical areas that were developed by our Department of Health that are essentially aggregations of zip codes, 2 or 3, that lump up population into a sufficient number that it becomes hard to identify patients, even if you identify a specific area. And then we played around with various ways to normalize that data and make the maps more informative. So we looked at visit volume, total visit volume throughout the Intermountain system to all the ambulatory primary care facilities. We looked at it by testing volume. We looked at it by population in those areas and came up with some ways to create activity levels based on the relative activity in each of those areas. What that ends up looking like, this is just an example of our prototyping tool to show what the different normalizations look like. And then you can start to march through and sort of see how an epidemic spreads throughout Utah. So we think this provides some information, at least starts to make it look pretty and put it on a map. In the future, we want to make it such that somebody we might know the location, for example, from their smartphone or from their computer and be able to say, hey, here's what we're seeing in your region, but we're a little ways off from doing that. Moving further down that consumer site, that web page, what are the common signs and symptoms associated with that pathogen? This infection timelines, which I'm going to drill into on the next slide. What's the mode of spread, so people can understand how they may have gotten it, and then what can they expect if they come see us in terms of diagnosis and treatment? A lot of it is you don't need to be tested. Our docs are really good. They can tell what you've got. You probably aren't going to need a treatment other than supportive care, but for certain places like influenza, that there's antivirals available. All right, so these timelines, we developed, they're sort of a brand new thing. We came up with the notion that there's a few things you want to convey to a patient, and I find these things really helpful now discussing with parents because they have a lot of questions about when did I get exposed to this? Was it at that birthday party? Was it at the little gym, which I affectionately call Little Germ, where people can go spread things? Was it, and then can I expect that symptoms start? And then what are the most prominent symptoms, and do they come in a sequence, and when can I expect them to go away? And then another important piece is how long am I going to be contagious? When's it going to be safe to go visit grandma or to go back to school? So we put that all in one package. And here's a version of influenza. And this was all, we did our best to go through whatever published literature was out there about these various time periods. And interestingly, not surprisingly, all these time periods also track into parameters that you can put into mathematical models for these diseases, which we'll get back to at the very end of the talk. So what's the latent period, what's your infectious period, those type of things. But influenza, for example, this one you'll be seeing a lot. It started with high fever, and they may have been contagious a day before they even started with symptoms, which is always scary. Headache, aches, muscle pains, fatigue that can last out for 2 or 3 weeks, sore throat, stuffy nose, that dry cough lasting for weeks, contagious for 8 days. I mean, these are the kind of tools that I can show somebody and say, hey, you sure you don't want to get that influenza vaccination? You sure you want to go back to work when you're not quite better? You want to expose all your coworkers? And then perhaps more interesting version, adenovirus, where you got a couple different illnesses. You got a respiratory illness and you got a gastrointestinal illness with very different exposure periods and contagious that can last for weeks and weeks. So we've developed these for most of our respiratory pathogens. Still have a few holes, but these feature prominently in our website. And then lastly, getting back to that, I want to be prepared. I want to know what to watch for. I want to know how to when should I act? What should I do? So we put together guidance about those things. Big one's prevention. Washing your hands, disinfect, cover your sneezes, use your tissue wands, sort of the basic stuff. And then watching for in parainfluenza, for example, you want to watch for croupy bark-like cough. Breathing, wheezing, all these things that sort of routine advice, but just putting it all out there in one spot. And then what we've done with the website is to then also make it kind of actionable. You imagine a parent reading through this and think, yeah, maybe that's what my child has, and I'm starting to get a little bit worried. Not worried enough to pack them up in the car and go get help right now, but maybe I want to talk to somebody and maybe I want to figure out where I would go if things get worse. So you can find your doctor, you can find a location, and then the concept of getting care now. And if you click on that button, you get taken to, theoretically, this. Few different options. The Connect Care, which is Intermountain's sort of telemedicine offering, or you can get in line in an Instacare, which I'll show you what that looks like in a second, or if you're like 911, seek help, go to the emergency room. I don't know if that actually connects you to 911. I don't think it does. Haven't tried it. So the redesigned public-facing website actually is done in such a way that it fits on your phone. So it's what's called a responsive design. So you put all that together, all those components together, so that if you switch it and flip it onto a little mobile device, it still all fits in there, which is kind of cool. But it constrains what you can do from a visual perspective, but it makes it so you design it once and you can look at it on any platform, iPad, iPhone. And here, I'm showing how you can get to it from the Intermountain Health Hub application. GermWatch is on the first page there. Get in there, you get that high-level overview. You can look at the graphs, you can look at the maps, and if you click on the Get Care Now on that application, you can, again, those 3 options, but if you click on the Get in Line at an Instacare Now, it'll actually pull up a map close to where you are. And this was from yesterday, and they must have been having a really bad day, and influenza is really hitting them hard because a 2.5, 3-hour wait at Instacare is pretty long. And you might decide, I'm not going there because that waiting room is going to be full of influenza patients, and I'm not going to go get exposed, and figure out some other way to take care of yourself. But you can start to see the footings of a new paradigm of how you might get care, right? If I can come up with ways to capture what somebody was looking at, what they were worried about, bundle up some information about them and their risk factors, and they decide to go seek care, boom, you could start to show that to the person on the end of the Connect Care telehealth consultation, or you could surface it up to the people that they end up seeing in clinic so that they hit the door knowing a lot about this patient, what their needs are, what may be the best plan of care for them. So we've been trying to get this information out in a number of ways. We have a Twitter account, hasn't been very active, looking to make that more active in the coming year. We've done some interesting things that are called live chats on Facebook, where we sit down and with the Intermountain moms and talk through RSV, paraflu, and you'll get like thousands of new moms out there asking questions, and a really compelling way, I think, to interact with our population. We've forged some news partnerships with the local news affiliates to get stories out there and sort of engage them and let them know that we have this capacity to sort of say, here's what's coming, or here's what's going on now, and try to surface experts. I try to get Andy to do it as much as possible, but he's not always available. And then website traffic, we're putting analytics on these tools so I can see what's happening in terms of visits and getting familiar with that type of data, and seeing pretty good traffic in the throes of cold and flu season. So we've gotten some good sort of press about that, with KSL in particular helping us sort of get this word out and doing features about our applications and websites. And I find this stuff, I was initially really resistant, but now after I've done it a few times and been embarrassed on like Fox 13 News, I feel like it's a compelling way to get that message out. And I hope people are out there listening, because then you can say, hey, flu's out there, we expect it to be bad. These are, it's in the middle of the day, somebody's watching news in the background, that maybe they're getting their kid in to get immunized. I don't know, but hopefully we are making an impact. And I particularly like the notion that we can tell people, like, for example, last fall with parainfluenza 1, we know group's going to show up. We can count on it. We'll talk about that again in a second, that we can get that information out ahead of the curve and really try to inform people and have them be prepared. So what I'm shooting for, and this was a graphic that Chris Maloney and I sort of came up with as we're thinking about this, is you've got this notion of a shared decision making. So this is in the case that they actually do come in to see you. So patients and parents may have some concepts, knowledge, attitudes, and beliefs about acute respiratory tract infections that are sort of way off. Can we sort of channel them in through tools like GermWatch to have a pretty good understanding of what those respiratory tract infections are and what can be done about them? Providers, hopefully they have good knowledge and positive attitudes and beliefs about these infections. But with these tools, I think we can sort of start to bring them together and have a shared understanding that'll make it a lot easier for us to figure out what people need, address their needs, desires, and goals more effectively, and make it more satisfying for both the provider and for the patient, and provide high quality care in the process. All right, one more gear shift. I'm sure you've all seen this quote. And this is what I get asked about a lot in the hallways. So what can we expect this year? How bad is it going to be? What's it going to be like? And I slowly getting better at answering those questions. And some of the studies we've been able to do as a result of the data that we've amassed in our resource are pretty cool things. So you may or may not know that RSV alternates, big, small, big, small, big, small. But a closely related virus, human metapneumovirus, also alternates big, small, but kind of in an opposite pattern, which is interesting, right? Parainfluenza, that should be PIV, not PRV. Parainfluenza 1 and 2 do this very consistent dance. Parainfluenza 1 comes around in the fall of odd-numbered years and has for many, many years. And why is that? What is that dynamic but somewhat predictable pattern? Why is that happening? So we, Kent and I, partnered up with some very smart mathematicians and evolutionary biologists on Lower Campus. Went to them and said, hey, we've got all this data, there's these interesting patterns, can we try to make some sense of it? And Samit, one of Fred Adler's graduate student or postdocs, got to work on this problem, and just summarize real quickly a bunch of geeky math that I probably couldn't explain to you very well anyway. We found out that there was a pretty strong signal that cross-immunity, it can explain that dynamic pattern. Because these viruses are pretty close on the phylogenetic tree, and they have some conserved, fairly well conserved epitopes that go across RSV and metapneumovirus, for example, on the F protein, which is the fusion protein, which is sort of the target of some of the neutralizing antibodies. That we think if you're unlucky enough to get RSV but lucky enough to get an antibody that targets both of those, you might be spared from metapneumovirus, for example. Or if you get metapneumovirus, and you might be spared from getting RSV the next season. So you can start to get that idea. There's been broadly neutralizing antibodies isolated that people have figured out neutralize both RSV and metapneumovirus. And then recently some structural biologists in Stanford have sort of figured out exactly where that focus is on the pre-fusion version of the F protein. So we thought this stuff was pretty cool, that the GermWatch data is helping us understand what's happening with these dynamic outbreaks. From a what's next, cutting edge prediction forecasting, so that potentially gives us, okay, we understand this, we can see these patterns, I can at least predict and understand why we're going to see these things the way they play out. What we're trying to work on now is better projection forecasting capability. We started with influenza, which is notoriously hard to predict and forecast. RSV is pretty predictable. Some of the other ones are pretty predictable. But the tact we're taking is very different. And for this project, we went back and we're collaborating with our colleagues in Pittsburgh, this Rod's lab that we did the Olympics work. And instead of looking at just chief complaints, which is very minimal data, or being dependent on laboratory confirmation, we decided to go after case detection using those, as I alluded to earlier, emergency department dictations, data that's available in the clinical record. So we put together many, many years worth of ED notes throughout the Intermountain system and the Wasatch Front. We built natural language parsing tools that go through and extract 72 different features: cough, sore throat, fever, respiratory distress, wheezing, all those things that might help you sort of figure out an influenza illness. And then you can take all those chopped up notes and those findings, and you can feed those into various mathematical models. Currently, we're using a Bayesian case detector that can then assign a probability to basically any patient. So every patient gets screened for influenza, whether they were there for a cut toe or whatever. You'll get assigned a probability whether you have influenza or not. And once you have sort of that uniform screening of everybody, then you can start to pass those numbers off to a pretty fancy outbreak detection system that Pittsburgh folks have been working on. And to summarize that, I mentioned that you can mathematically model all these outbreaks just by understanding some of the transmission parameters. And if you have 1,000 different models that are tweaked slightly differently based on the incubation period, those types of things, that you can compare this week's data to that library of models, and you can pull back a couple models that are probably the best fit for that week's data. So that's some of the stuff we've been exploring. This is just an example of what we did for influenza outbreaks. We wanted, you can get A, you can get B, you can get them sort of offset because of different serotypes. We wanted to figure out, well, number one, how good is our case detection for that? If you use these methods, we were able to get up to 0.93 for an area under the curve for influenza case detection. And something that's also really cool is having GermWatch type information with knowledge of what's circulating already. You can improve that detection by feeding those priors into that system. The outbreak detention is pretty sensitive and specific, and for influenza, we can predict that peak date, plus or minus, less than a week, a few weeks out. At least we think we can. We're working on similar case detectors for RSV, metapneumovirus, parainfluenza virus, but as you can imagine from what I've described, this one's a little tougher to implement than just tallying up laboratory results. I've got to have real-time feeds of ED dictations and then a way to pass those off to this other system and a way to pass that back and put it in an interface for us to use. But we're getting close. So with that, I wanted to summarize and thank some of the funding organizations along the way. PCMC Foundation way back when, and the Department of Health provided some seed funding for sort of earliest versions of the rudimentary GermWatch system. ARC has funded some of my work, CDC's funded some of my work, and more recently, Intermountain's Healthcare Innovation Fund has been supporting some of the GermWatch development. And lots of help from Intermountain Healthcare and obviously the Department of Pediatrics. And I've left 10 minutes for questions.
Questions?
Per, that was brilliant. I especially love the evolutionary biology component. That's great.
So I didn't know that existed before I met.
So I actually have a cancer-related question. In the field of cancer, there's a lot of debate and discussion whether there's a contribution of infection and seasonality, especially in the blood cancers, especially after school vacations and exposures. I wonder, is there a way, if we change the input to put in data from the Utah Cancer Registry or the SEER database, that we could have such a visually stunning output to look at, like you've set up for GermWatch? And then is there a way to overlay these cancer rates of seasonality with the GermWatch data that you've generated?
My quick answer to that is that there has to be. I mean, we have an amazing data resource, and I think it's being underutilized, and I think that's a great example of how we could sort of look at correlations, try to tease out signals, and we would definitely look into talking with you about that more. I haven't thought about the cancer one. We thought about diabetes, for example, and talked to Mary Murray and some of my informatics folks about how you might start to mine and look for signals that might sort of talk about that. But that could be very compelling.
I think that guy was on the airplane with me 2 days ago.
Andy has a question.
I take you back to one of the initiators of the work, and that's in biologic warfare and bioterrorism. But tell us where this now is fitting across the country, if you can, if you're not.
No, I'm not constrained. So I quickly sort of diverge back to clinical care, and then obviously nothing's really happened in 10 years. So there's a lot of money, a lot of focus put into that. The CDC picked up on the syndromic surveillance. They turned those chief complaints into, that actually was a meaningful use requirement for a while, reporting syndromic surveillance data. They've been trying to build on that, trying to get ICD-9 codes, trying to get a signal. They're going for low-hanging fruits, that are easy to implement and can give them broad coverage. And that system's pretty well taken off, the BioSense program, gone through several different iterations. They're not far enough out, I think, on to reach into the clinical environments to get even better data, just because everybody's still sort of fragmented. I think some of the directions we're headed with being able to have portable case detectors, that's the part I didn't showcase with the Pittsburgh work, is can you come up with a system that allows you to build a case detector that can be ported to another system, and we demonstrated that we could build one in Salt Lake that worked pretty well in Pittsburgh, and vice versa. So I think we need to move in that direction where you're able to get deeper, richer data, and you need to get that sort of consistently, because the way you're going to be able to detect bioterrorism is sort of a person, an astute clinician who's sort of thinking about it and recognizes perhaps that, oh, this patient has a flu-like illness and some findings that suggest a specific pathogen, and we're not seeing a lot of viral illness, I think is that we're going to have a good baseline so that we can look at things that stand out from what is the norm of natural bioterrorism that gets us every year. So I think those systems are progressing. The other thing we're working on is ways to take GermWatch and do it in other places. How can you get that laboratory data out quicker? We did an interesting collaboration with BioFire so that the machines themselves can actually report out to the cloud, and have shown that you can get the machines directly to report to a cloud-based system. I think those are all sort of steps in the right direction, because then if you have a signal where you're saying, okay, this is explainable, this is expectable, but then can you see something that bumps up above what you're expecting based on what's happening right now? Those are the kind of signals that are going to need to be detected. And I think we're a ways off from having that capability at a national level.
Sarah, I think you were kind to BioSense, since basically they scrapped version 1 and considered it a sunk cost and started from scratch.
They did fund me a little bit, Andy. I got to be careful.
And they've taken off in a new direction. So Per, you started out with this incredibly important goal of getting physicians to reduce inappropriate treatment and to get patients not to seek expensive care when they didn't need it. And you put these tools in their hands. So what are your thoughts about how we're going to measure those ultimate endpoints of improved antibiotic prescribing and perhaps decreased utilization for viral illnesses?
Right. That's been somewhat of a thorn for me, because of the way we've rolled this out. Is we have an idea, compelling system, a lot of enthusiasm, quick, get it out there, and missing opportunities to find totally naive populations that haven't seen this and don't know about it, right? So one of the approaches we're taking is to go through our entire list of users, do our best to identify who we think are power users, and capture what their prescribing patterns have been over time, and in a sense try to do sort of a pre and post. So what proportion of patients are getting antibiotics for routine conditions that shouldn't get antibiotics, and compare them to a group that perhaps hasn't seen GermWatch, although I won't know that they've not seen GermWatch, and be able to see if there's a difference between those two types of patterns. And potentially we could do that with other organizations that are outside of Intermountain that wouldn't have seen it. But as I look through my user list, there's people all over, and I think this information's percolating in a lot of different directions. But just looking at prescribing patterns, a lot of what we've done to validate this has been survey-based, I'll confess, and the survey data has been really compelling and positive, with people saying that it really helps them make decisions. But yeah, that is something we need to prove even better. The consumer side of things is an even harder nut to crack. What we're trying to accomplish with that is build a more complete, what they're called customer relationship management systems. So I want to do what we've done with clinicians to potentially set up an email distribution service alerting system with them, as well as be able to track who's visiting the website, pop up and survey them about, did this help, did this change what you do? Can I look and see click-through rates for somebody who was on the site, and then click through to Connect Care and find a way to capture what happened and how that changed their behavior. Those are the broad stroke of how we're trying to go after that. Open to suggestions, of course.
Prediction on the peak of influenza?
As I mentioned, I don't have that system running just yet. But looking at some of our previous curves, I don't know, Andy, what your thoughts are. I'm thinking that I wouldn't be surprised if it peaked in the next few weeks, perhaps.
Have the typical 8 weeks or about 4 weeks from major upturn to peak that Harris demonstrated in previous studies, then we're probably 1 to 2 weeks away. And we've already surpassed the activity's higher than any of the previous 10 years already.
Yeah.
And the coverage, Andy?
So we don't have any estimate this year for vaccine efficacy. Last year's U.S. data on virtually an identical strain suggested that efficacy of the vaccine was about 30%. So better than what you read about from Australia, but still pretty poor. Interestingly, this is due to, we think, to a mutation that occurred in adapting the virus for egg. So if you can find any of the cell culture grown vaccine out there, it may be more effective. Unfortunately, there isn't enough of that out there that we get a real point estimate of its efficacy. But next year, we're going to look into how much cell culture-based vaccine we could buy. That's for H3N2, the current strain. B, it's better. B, it's 50-something%.
Can I ask a final question? This is the brag question. Tell us where you are compared, and maybe if you have a moment. This approach to surveillance.
I don't like these kind of questions, but I'll try to answer it. And actually,
you're standing
even putting that picture of myself up there, it was hard to push click on that. I still think we're probably at the bleeding edge, I think, in a lot of ways. A lot of that still relies on the fact that we've got data integrated systems and we've got a really compelling structure that way. I think people are maybe going to start to catch up. I think what's happening with BioFire and demonstrating that you can have the machines report out is both a threat and an opportunity, but you still need to be able to connect it with zip code data, other kind of data to get really the rich kind of information that we get out. I think people are ways off from that. So we're trying to figure out how we could take this to other places. As we've gone through that, some of our competitors that we've looked at where GermWatch might go are things like sick weather, which I don't know if you've looked at that. It's you hop on there and I'm sick, but with very limited information about what's actually making them sick. So people that are trying to do this at a broad level, I think are struggling to find good signal. We have really good signal, but it's constrained by this system and the type of data that we have. I think the real trick is going to be to bust out of that. Nationally, I would say, Andy may comment about this better because he goes to the CDC and I think they see the application and I think they are impressed by what we have locally. As I present this stuff at meetings, I don't have a lot of people coming up, but you're starting to see people pop up, what's going around in their areas with various approaches, some using ICD-9 codes and other things like that. So I think in terms of pathogen specificity and being able to say it's exactly this and providing compelling educational content alongside it, I think we're still leading that pack. Globally, I don't know. There's huge advantages to people that aren't mired in legacy information systems and have national information systems, and I think they're starting to do some of this.
I think that was a pretty humble answer to the extent of his work. Per, thank you.
Thank you. Appreciate the opportunity.
I'm going to start showing patients.